Well, hello, everyone, and thank you so much for coming to the Clinical Research Forum for October. I am so pleased to introduce Dr. Amy Kind. She is a tremendous researcher and leader and is going to be talking to us about some of the work that she's done that really to me is just fascinating. I was just telling her I've heard her talk about this several times, and I always walk away just knowing a little bit more, and it's so fascinating to me. So I want to welcome Amy Kind to our Clinical Research Forum. And Amy, I will let you take it away.
Great. Thank you so much, Betsy. I want to thank you, Betsy, and your entire team for inviting me to present today. This is really quite a treat. As Betsy mentioned, I am a faculty member here at the University of Wisconsin School of Medicine in Public Health. I'm a professor of medicine, but I also serve as Associate Dean for Social Health Sciences and Programs. So I will be going through a introductory whirlwind tour of the construct of the exposome and then leave some time for questions at the end. So if you do have questions, feel free to put them in the chat. We will take a look at them. But without further ado, I'm going to go ahead and share my screen. And I'm hoping someone can unmute and tell me that you can see this before I get started. Betsy, Kevin, anyone, can you see this?
Yep, we can see it.
Okay, great. Thank you very much. All right. So we are going to go ahead and get started then on this whirlwind tour. I will start with my funding disclosures. I received funding from the National Institutes on Aging. Some of the work that you will see here presented was funded by the National Institutes on Minority Health and Health Disparities, and I have received funding from the Alzheimer's Association in the past as well. This is my email address. If you'd like to send me a line, feel free. So first of all, let's talk about some basic definitional constructs. The first construct I'd like to cover is something that you all are probably quite aware of, and it's this construct of precision medicine. So precision medicine typically involves deep phenotyping of factors that are unique to an individual's biology. So what makes each of us unique? What genetic aspects, what kinds of molecules, what types of physiology? And using that information, the hope is we can provide better information on diagnostics, therapeutics, and ultimately cures and mitigate disease for many. Yet we also know from your fundamental biology classes that you may have taken early on in your career that health is not just the sum of our genes. There are some diseases that are primarily genetics based, but the vast majority of diseases include factors that involve both genes and environment. And yet in the field of precision medicine, this environmental factors, these types of factors are less often included when we try to predict risk or to design therapies. So, the other interesting thing when we consider the environment is that many of these environmental exposures may be modifiable. So, they potentially not only serve as tools to potentially better predict an individual's risk of disease or tailoring of those therapies, but we may be able to intervene as often at a societal level on those exposures themselves. So this becomes important in the construct of the exposome. The exposome is a term that was just coined in 2005. It is very, very new in the field of research, but this is its official definition. It's the measure of all of the exposures of an individual in a lifetime and how those exposures relate to health. Often, the big challenge of the exposome is one of quantification and measurement. This was from a Science article in 2020, in which we can also conceptualize the exposome as all of those factors external to the biological individual. Again, this is very much in line with a next generation precision medicine construct. And these types of external factors are diverse indeed. They can range from the microbiome, which is technically external to the biological individual, although it may be within the gut and within our bodies, but it's not within our bodies biologically. And it ranges all the way through to structural inequities and the different types of exposures that can happen because of that. There are four major domains of exposome exposures. They include ecosystems, things like the built environment, social exposures, physical and chemical exposures, and lifestyle exposures. The exposome is hard-coded in many health disparities research approaches. I'm showing you a simplification of the National Institutes on Aging Health Disparities framework. This framework looks a lot like the other NIH frameworks that focus on health disparities, and they include exposomal factors along with many of the other factors. So things like environment, sociocultural factors, and then of course behavioral and biological factors, none of which operate independently. They are all interdependent on each other and all interact to either produce wellness or disease across an entire life course. So someone like me, who is a health disparities researcher and very interested in root cause mechanisms for health disparities, I need to think about the exposome as well as all of these other factors as we study these diseases, we study disparities, and try to design approaches by which to mitigate those disparities. The NIH is very, very interested in this construct as well. And this is very hot off the presses. This is a brand new, just a few weeks old office of the National Institutes of Neurological Disorders and Stroke that was just established specifically to study the neural exposome. There's, as I'll show you later on in the talk, there is ample evidence now that the exposome impacts brain health in a profound number of ways. And our team was asked to advise on the social exposome factors for this office. So do stay tuned. There's lots of opportunities here for those of you who are researchers and going after NIH funding, but in particular, NINDS just launched this. So many individuals say, well, could the exposome just be a measure for individual level factors? Is this just a surrogate level marker for someone's individual level poverty or education or other types of individual level traits like sociodemographic factors? And the answer is a resounding no. And this is an important takeaway to take from this lecture today, is that the exposome factors, including those social determinants at the exposome level, and the individual level factors operate fully independently in terms of their impacts on health. And the best example of this comes from the Moving to Opportunity study. The Moving to Opportunity study was a natural experiment that was launched during the Clinton administration in the 1990s. The Department of Housing and Urban Development during Clinton's years decided to try a new approach to eradicate poverty. And what they did was to offer specialized Section 8 housing vouchers to families that would typically have qualified for Section 8 housing, low-income housing. But these vouchers, if you were lucky enough to receive one, allowed you to move to neighborhoods with housing costs that were higher than traditional Section 8 housing. This rolled out in 5 cities, 5 urban areas across the United States, and there was such interest in the program that they conducted a lottery. They did not have enough vouchers for everyone, so they used a lottery, and if you were fortunate enough to get one of these vouchers, you were able to move out of Section 8 housing and into these other neighborhoods. There were some economists and sociologists from the University of Chicago that were very brilliantly recognized this as a natural experiment. And they were so interested in whether this would be an answer to poverty. So they were primarily measuring economic factors and including individual socioeconomics. This was the primary outcome of this particular natural experiment. And they were interested in seeing if these families would have incomes that would lift them out of poverty. And so they compared the families who received the vouchers, those who didn't, and what did they find? No change. Individual level socioeconomics, individual level education measures, individual level markers of a whole host of things did not change. They were measured very, very carefully, and yet they did not change. There was no difference from before the move to after the move or difference between the 2 cohorts that were studied. But they had a few measures of health that they collected at this time. And although there were no changes in the individual level socioeconomics, the health measures markedly improved with this change of social exposome. So these families that moved, that received the vouchers and moved, had better outcomes in terms of diabetes, obesity, cardiovascular disease, and mental health outcomes. And since this time, these cohorts have been followed forward for many, many years. There have been hundreds and hundreds of studies published on this, with some of the landmark studies coming out in 2010 and 2011. You can see the citations here: New England Journal of Medicine, Science, and all of these were noting the independence of the individual level factors as compared to the neighborhood level factors, in this case now relabeled as exposome. So of course, I could show you hundreds of other studies that show this lack of interdependency and full independence of these two factors in terms of their impact on health. But please remember this: when we think about measuring different markers of the social exposome, different quantifications of the exposome, it's not just to take the place of individual level socioeconomics. Individual level markers are important too, but the exposome level markers have their own impact on health. So here at the Center for Health Disparities Research, or the acronym is CHEDR, CHDR, so very Wisconsin appropriate, just like the cheese. We are building infrastructure designed to support exposomal study, particularly NIH-focused exposomal study. Our mission is to catalyze research, clinical innovation, and educational activities in this area, to grow and nurture our scientific community, and to ultimately bring the benefits of this type of research to all persons. When we examine the exposome, I and my colleagues at Cheddar think about it in three steps. The first is we have to take social factors, which are often somewhat difficult to quantify, and create metrics that are rigorous, valid, and harmonizable across space and time. This quantification of exposures is a whole field unto itself. We could spend hours and hours and hours talking about this, but I'll touch on it just very, very briefly during the talk today. Next, we have to take these exposures and link them to biology. And often our strongest biological resources, the biorepositories that have been very exquisitely characterized, have no social factors whatsoever. In fact, often the linkage to identifiable elements that allow for the linkage to social factors have been fully broken or fully de-identified. So the question comes, how do you link in those situations, and how can we add things back? And then finally, how do we link these types of constructs to action outside of the research space? So first, quantifying. So each of these four domains within the exposome has entire departments and careers dedicated to quantifying the factors reliably and rigorously over space and time. So this is an area that I am touching on very, very, very briefly, but do be aware, if you're interested in this, there are a whole host of other quantifications available. But I'll just share one that has become a dominant social exposome quantification within the United States. So our center is really the leader now in social exposome quantification. This is the reason I was asked to advise on the NINDS new Office of Exposomal Study, and I often have a seat at the table at a number of other broad scale policy and research initiatives. But these metrics are available to all of you as well. They're housed within the Neighborhood Atlas, and the metric is called the Area Deprivation Index, or ADI. The ADI is a very small level population sensitive metric that includes measures of housing quality, income, education, and employment, and allows us to characterize the exposome at a very, very precise geospatial level. These metrics are produced by our team. They are updated annually. They're provided in a rank-based score, either for each state in the United States or for the full US. They're time concordant, and they're extremely strongly linked to health. So what do these things look like? So the map on this slide is a map of Milwaukee County. So this is a single county, and I'm sure all of you have seen county level metrics, county level rankings, and an understanding that Milwaukee often is ranked as a very challenged county. But when we use this much more geographically precise measure, what do we see? We see red areas within inner city Milwaukee. Now, these red areas denote these very precise geospatial block groups of high ADI. And then we see blue areas within the same county, which denote low ADI neighborhoods. And sometimes they're right next to each other. In fact, Milwaukee has some of the largest differences in terms of ADI and also income disparities within the state of Wisconsin. Those red areas clustered within inner city Milwaukee are the most disadvantaged by ADI and do map directly onto historic redlining practices and other types of racial and systemic inequities that have occurred within that city and within the county. But this much more precise measurement allows us to measure exposures in a way that then links better to fundamental biology because we don't make an assumption that the whole county is the same. We can determine these exposures with much more precision. So the ADI is distributed free for all through the Neighborhood Atlas. It is right now truly the dominant disparities aligned US exposome metric. We've had, not our team, but the research community writ large has had over 1,200 peer-reviewed studies using the ADI since 2019, since its release, and just 850 in about the last 12 months. The tempo of use has increased dramatically. Right now, in previous metrics that I've built and previous sharing tools that I've created, we would have been happy with 1,000 downloads over the lifetime of the tool. That would have been trumpeted as a huge success. And right now with the Neighborhood Atlas, we're getting 1,000 downloads of these data weekly. Right now, we're well over 100,000 total downloads, and each of these data sets has about 79 million data points. So it really does allow others to use this data, to work with the data, and then to make meaning of the data through the maps. This is all supported by our Center for Health Disparities Research, Cheddar, here at the University of Wisconsin. And I'll go into the state and federal policy uses at the end of the talk. This is what the full state of Wisconsin looked like. So the map that I previously showed you was that zoom into Milwaukee. You can see it very tiny there down in the lower corner of the state. But the geographic areas that we use are called census block groups. They're population representative. So each of them includes about 1,500 persons, and they're defined by the US Census. So within rural areas, they tend to be geographically larger, and in urban areas, they are very, very small indeed. And what you can see in the state of Wisconsin is that those red areas, again, the areas with the highest ADI, tend to be within our rural northerly areas. They tend to be within our Native communities, Native American communities, and then again within the inner city. But the power here is we can do this for the full United States, every block group, every city, including Puerto Rico and the District of Columbia. When we look at the distribution of highly disadvantaged neighborhoods by ADI in the US, they are more often located within urban city cores, like in Milwaukee, or in these highly rural areas, like we see in the northern part of Wisconsin, as well as in our Native American communities. There have been thousands of papers. I can't list them all that have used the ADI, but just some broad scale brush strokes. ADI has now been strongly linked to more rapid aging, including acceleration of epigenetics. And this finding has been duplicated in multiple studies now and cross nationally. The ADI does harmonize with similar metrics in other countries, so it allows us to do cross national harmonization with these types of genetic studies. Has been linked to higher costs of care, greater risk for rehospitalization, more trouble accessing care and diagnoses, greater risk of post-surgical complications, poorer post-surgical survival, increased cardiovascular risk, lower survival overall. And in those last years of life, individuals who live in high ADI contexts tend to have more disability and many, many other factors. This is an example of how we can also look at multiple intersectional characteristics in our disparities research using the ADI and other individual level factors. So this was a study that came out of Brown that was led by Amal Trivedi and colleagues. He's a very high level researcher who focuses on Medicare Advantage programs. And what we see here is a listing and an assessment of cholesterol control. So, as you might imagine, higher cholesterol control is better. So, on this graph, higher numbers are better on the upright axis. And on the horizontal axis, we have ADI listed from the lowest, or again, those blue neighborhoods, the least disadvantaged, all the way up to the most disadvantaged. And then you see multiple lines here by self-identified race of individuals who are being cared for in these health systems. So the first thing to note is all individuals, regardless of race, if they're living in a low ADI context in these blue neighborhoods on the maps I showed you, tend to have better cholesterol control than all other individuals who are living in the high ADI context, the highly disadvantaged neighborhoods, regardless of race. However, across ADI ventiles on this particular study, you also see racial disparities. So if an individual identified as African American, they tended to have poorer cholesterol control than their other counterparts, regardless of the ADI of the neighborhood they were living in. So this is a nice example of an analysis that not only shows us a disparity by social exposome, but a disparity by race as well. And these types of disparities, these types of analysis can help us tease apart the different fundamental factors that are attributing to differences in health outcomes. So moving on from quantifying the exposome to linking to biology. So this process of linking these social factors to fundamental biology can be described as social biological phenotyping. It allows us to take these exposomal level factors and potentially link them back to deeply characterized biological tools, biological samples. And this allows us to open doors on entirely new analyses, often to biorepositories that have been very deeply characterized, and yet often there's very little known about the social factors. So how have we done this within our own work? I'll show you a series of just a few studies from the brain health space. My team tends to focus on Alzheimer's disease, brain health, and risk. And so just as an illustrative example, we'll start there. So this first study was a cohort of individuals who are living. These are individuals who are cognitively normal, recruited from the Wisconsin Registry for Alzheimer's Prevention and the Wisconsin Alzheimer's Disease Research Institute, and they've been followed for some time. So, with our first step, the first author on this was an MD PhD student just here from the University of Wisconsin, which is great. And we assessed where individuals were living and used that assessment to link to ADI at that time, cross sectionally, and then to link to their MRI markers of total brain tissue volume and hippocampal volume. And the hippocampus is the seat of memory in this case. And what we found is those individuals who are living in the 20% most disadvantaged neighborhoods, or again, these highest ADI categories, those red neighborhoods on the map, had lower total brain tissue volume as compared to their counterparts, and also lower hippocampal volume as compared to those who are living in the 80% least disadvantaged neighborhoods. Now, we also, Dr. Hunt also conducted mediation modeling to see if he could explain some of these differences. And interestingly enough, the total brain tissue differences could be mostly explained by cardiovascular risk, diabetes, smoking, heart disease. These types of phenomenon seem to explain a lot of the differences that were seen between these two groups in the total brain tissue volume. However, those cardiovascular risk factors did not explain the differences seen in hippocampal volume, thus leading questions about whether different types of mechanisms could be going on there, in also involving perhaps early life development and cognitive reserve. So you may say, well, that was just cross-sectional, that could perhaps just be a correlative finding, which of course it is. But we were interested next at looking at longitudinal data and seeing if these findings would be robust enough to stand up. And what we found is that looking over 10 years of data that was available within this cohort, living in the most highly disadvantaged neighborhoods over those 10 years was associated with accelerated degeneration of the brain. So the cortex of the brain thinned more quickly in these counterparts, comparing them to where they came into the cohort to where they were at present. And this was associated with more subtle cognitive declines. So these individuals were basically having their brain shrinking more quickly than individuals that were living in the low ADI contexts. Since that time, there have been a number of different studies that have looked at childhood brain development by ADI using the metrics that we have available on the atlas and then linking them to neuroimaging assessments of childhood brain development. This is one example study out of Columbia looking at a cohort of children out of the New York City area. And what they found in these kids between the age of 5 and 25 is that the brain images differed remarkably between kids who are living in the high ADI context versus the low ADI context. And for this study, as well as all of the other studies I have shown you, all of these findings have been adjusted. These findings were adjusted for individual level factors, for age, for other demographics, and for comorbidities. And so these types of findings are interesting because they're suggesting that there's something within the exposome that is associated with these differences in brain health. And it really raises opportunity to potentially study more. But the gold standard in Alzheimer's disease is not made just with imaging alone. It is made, well, this type of imaging in particular, it is made with tissue. And so we wanted to ask, could we take neurotissue and add back social factors in a way that helped us to understand more about these tissues? And so we worked with the University of Wisconsin and University of California, San Diego brain banks to understand more about the donors, the brain donors that had offered their brains to science with the hope to find a cure, often for neurodegenerative diseases one day, and looked at those individuals and realized very quickly there was no social factor characterization available. Often, we would know quite a bit about the individual's genetics, about their different types of very precise biomarkers within their tissue, and yet we would often know almost nothing about their social factors. So we were conducting a feasibility study just to see if we could add these things back. And this feasibility study involved these two sites. It involved 453 decedents, and we asked for and obtained the autopsy records for each of these decedents, took the address on those autopsy records and geocoded it in a time concordant fashion. So they could have died from 1993 to 2016, and then linked those geocodings to time concordant ADIs for those same periods. Our team can build ADI all the way back in time. We've built them back to the 1900s. And so this allowed us to understand more about the address at the point of death for these individuals and how that was associated with neuropathology. This was powered as a feasibility study, but the association was so strong, we had a positive signal, even with this smaller feasibility study size. And what we found was that those individuals who were living in the highest ADI decile had a marked increased odds of AD neuropathology burden in almost a dose-dependent manner. So the higher level of ADI at the point of death, the higher the amount of amyloid plaques and tangles within the brain. This study was published in 2020, and since then, the ADI work in the brain health space has absolutely exploded. There are so many wonderful, wonderful studies moving forward, and it's just really, really great to see. But yet again, this is a cross-sectional study. And the question we have is, exposome really is a life course construct. Can we understand more about the dosage and timing of this type of ADI exposure or any sort of adverse social exposome exposure and how that links to brain tissue and brain health? This led to the neighborhood study. The neighborhood study is a $37 million R01 funded by the National Institutes on Aging that is the largest study of its kind to link social exposome factors to brain tissue and other brain health markers. We work with 23 sites and work very closely with them to get the infrastructure in place to do this study. I'll tell you about the infrastructure in just a moment. But it does require substantial lifts in terms of legal, administration, and operations infrastructure to do this work. So you might ask, well, how do we determine where someone who may have died in the early 90s, where they've lived across their life course? And we do this through archival study. We do this because we want to understand, well, if they haven't had an adverse exposure within their young childhood years, does that window of exposure potentially carry more weight or carry different types of ramifications for their brain health in late life as compared to different types of exposures in midlife, late life, or is it more of a cumulative exposure construct? The foundation that we are building with these studies by building these retrospective geospatial frameworks for every individual who's involved, both living and dead, allows us to also build research infrastructure that can be harnessed for other types of exposure linkage, especially exposome exposure linkage in the future. These are our sites. Our 23 sites are spread across the United States. Many of our sites have excellent racial and demographic representation as well. We'll have over 10,000 brain donors that will be characterized. Again, this is a phenomenally large number for a neuropathology study. And we build these life course exposomes through public data tracing. So I hire a very large team of archivists and analysts who comb through the public data, starting with individuals' dates of birth, dates of death, name, and address at the point of death. And we find all public records available for these decedents using standard and rigorous historical archival methods. Using this approach, we have been able to discover 73% of all person years for the decedents that have been characterized thus far. So this provides us with relatively complete timelines that then can be used to link different exposure metrics. In this study, we also enroll living participants, and the approach there is very simple. It just involves a survey. There are legal privacy considerations with this type of infrastructure. This is part of the reason we're the only group in the country doing this right now. It requires us to bring in protected health information from across all of these sites. So we have customized data use agreements with each of the 23 sites that take into account not only national HIPAA law, but also state privacy laws. But we have been successfully able to get those in place, and all of our sites with brain banks have now transmitted their names and address data for their decedents. We also need to have HIPAA compliant, very high level cyber infrastructure to ensure security of these data. We've partnered very, very closely with SMPH Informatics and Jamal Matthews Group in order to build cloud-based infrastructure to meet our needs. This has been a substantial undertaking. As I mentioned, biorepositories across the US hardly ever curate this type of data unless they are linked to a long-standing longitudinal cohort study. But again, most biorepositories are not that. So this approach could potentially be leveraged to characterize other biorepositories using other types of disease models. In the course of these historical records tracings, we also find military records. We open opportunities to link pollution and education exposures and a whole host of other things. So we are approaching this as a foundational exercise that will allow us to build infrastructure that then can be used to not only store, characterize, and create these residential history timelines, but then link exposure data in a secure and safe manner, de-identify that data, and then share it out with other research resource groups that don't have the PHI capabilities. So for instance, a biorepository for genomics often has fully de-identified data, but if we could share with them time concordant ADI scores, for instance, which are themselves de-identified, it would extend the ability for these other centers to ask really important questions. And this is our vision going forward. But in examining the exposome and in so much that we do in the disparity space, it's also important for us to keep in mind that as researchers, we should use research as a lever towards action. So how can we move forward in other ways? And our Neighborhood Atlas is our primary tool for that. The Neighborhood Atlas is our data democratization tool that was designed to be as simple as possible and as user-friendly as possible to allow open science to be accessible and usable to all members of the inquiring public, regardless of their background and regardless of whether they have a data science degree. We provide the data for free as well, but working with these large cohort data sets are not things that most individuals without a data science background can do. And so because of that, we provide customized mapping that works a lot like a smartphone mapping app in order to make meaning of the ADI scores. As of today, the data have been downloaded over 100,000 times by research, governmental, community, and industry group, and most of our users are outside of the research domain. So this tool is being used by a lot of community groups. They will take screenshots of the maps included in their grant applications or by governmental groups that are using them for a whole host of informative purposes. This is what the atlas looks like. Very, very simple tool. You just select your state and immediately a heat map comes up. And in the heat map format, red means high ADI, blue means low. Obviously, this is a state of Florida. You can see the difference between the urban areas with the tiny dots. Again, these are population sensitive block groups versus the rural areas with the larger geography. The areas in gray are areas that are either so sparsely populated that we don't calculate an ADI or they're suppressed for other reasons. This sometimes can happen where we have block groups that are primarily institutions like prisons or large hospitals or large nursing homes. For those areas, the underlying data that we use for calculating the ADI is not collected. We also allow states to be viewed from a number of different vantage points. So for instance, this is the state of Mississippi as compared to itself. So this is an ADI that is ranking Mississippi, all of the block groups in Mississippi, and the red are the areas that are most disadvantaged as compared to other block groups in Mississippi, and the blue are the least. However, if you click on that national percentile toggle, what you will see then is Mississippi as compared to the rest of the United States. And as you can see, most of Mississippi is deep red. This is a state that has more than its fair share of disadvantage. And I show this slide because ADI across the United States from a national perspective is not distributed equally. There are some states from a national ADI ranking that are mostly blue, and there are some states like Mississippi that are mostly red that have remarkably high ADI scores throughout. On the atlas, you can zoom in. And as you zoom in, additional geographic layers are offered. This is a wonderful technical build by our team that lets especially community groups and clinical trials groups, which we'll talk about in a moment, do wayfinding for reaching out to populations that might be at the greatest need, finding partners, other infrastructure groups within those red neighborhoods, and building new bridges and new collaborations. So for this talk, I wanted to highlight how ADI is now increasingly leveraged in clinical trials, and it is frequently leveraged in the brain health space. Just since that 2020 paper was published by Dr. Powell, since then, ADI is included in a huge number of brain health focused studies. So as an example of this, the Alzheimer's Clinical Trials Consortium, which is one of the big clinical trials consortiums that is funded by NIH, but used by pharma quite a bit, characterizes its participants by ADI and uses the ADI for a whole host of reasons. Additionally, the Adolescent Brain Cognitive Development Study, the National Alzheimer's Coordinating Center, and I could go on and on and on, listing the number of brain health kind of targeted infrastructures that now are characterizing their population by ADI. Pharma has been also very interested in this metric. I have had many meetings with large multinational pharma groups that are interested in using the ADI in a number of different ways. So how might they use it? Well, first, when we think about recruitment infrastructure and outreach, often there is interest, as there should be, in recruiting in populations that reflect the general population, that reflect the general society as a large. And obviously, often our trials and often our clinical cohort studies and other research resources are skewed to individuals that tend to be wealthy and predominantly white. And so the opportunity to look geographically at different clinics, different infrastructures that could potentially be partnered with, be invested in for building clinical trials recruitment infrastructure in certain areas of the United States that frankly may not always be in an academic hub, maybe in a community hub, is something of great interest to pharma as well as other types of clinical trialists across the NIH. Additionally, a lot of these groups are interested in doing secondary analysis of their data by ADI. So taking the existing clinical trials data that they have, using the addresses on hand, geocoding them, and linking them to time concordant ADI to make meaning of different differential impact, differential recruitment, representativeness of their existing samples, as well as outcome. And then, of course, there is a whole host of groups that are working on how best to collect the ADI, the processes for collecting ADI and including it in clinical trials data. Many times they include this as a point of enrollment collection. So the Neighborhood Atlas that I just showed you has a lookup tool in which you can enter in an address and immediately get an ADI, both at the state level and at the national level. Additionally, the data itself can be downloaded and hard-coded into different REDCap tools or other types of tools in which the lookups become possible. The ADI itself is just a number. A single ADI ranking within the United States represents over 13 million persons. It is not identifiable. The ADI itself is fully de-identified. And so because of this, it can be collected like other sociodemographic, other socioeconomic data, and increasingly is done so at the point of enrollment. Or, of course, with address data, these address data can be linked, geocoded and linked. The Neighborhood Atlas itself is incredibly widespread in use. NIH institutes from NHLBI to NIA, NIMHD, and others have used the ADI in cohort studies. I just gave grand rounds to the National Institutes of Environmental Health Sciences, who have a number of different programs that are using the ADI themselves. Professional medical societies have used the ADI in order to inform different types of equity assessment and monitoring. The Society for Thoracic Surgeons uses the ADI to understand who is able to access surgery and what their outcomes look like. Private insurers across the US are using the ADI to inform quality metrics that they receive, as well as payment policies that are moving forward. State Medicaid programs have been doing the same thing, and these Medicaid programs stretch from Florida to Maryland to other places across the United States. And then finally, the US Center for Medicare and Medicaid Services now is using the ADI across a number of its new payment models, including its ACO REACH model that I'll show you in a moment. It uses the ADI as its health equity benchmark. So when we think of trying to intervene on the different root causes, especially social determinants of health that impact differences in health outcomes, we become very interested in different programs of this sort. So again, social determinants are things like education, income, housing quality, social supports, health systems. And when we consider these types of programs and what's needed to actually intervene, it'll give you a sense for why groups like CMS are so interested in the ADI. So just to give you a little background then, if we were to try to intervene on education, for instance, early childhood education programs have a really big impact. Housing affordability programs, different types of social support programs for older adults, these things are all important. But the real question is who pays for them? Who supports them? All of these things require a lot of money and resources to sustain, and yet often they're desperately underfunded, as we all know. So the groups that are at the table, the groups that potentially could sustain these include government, which is the big player. They're the ones who usually do this at the federal, state, or local level. Nonprofits who often are mission-based and may run things like food pantries, for instance. And then industry has a small role, but I would argue it could potentially increase. In terms of the why might those three general categories of groups support social determinants? Well, the government does it because it's legally required to, right? Legal requirements, and that's really kind of the dominant feature within the current state of supports. Politics and mission play a role, especially for nonprofits. But market forces, when we think about that industry bucket, market forces is what drives industry so often. But this is rare in the current state. Rarely would you see an industry or a hospital group or another group reach into a high ADI context for market purposes. And so because of this, it has created a lot of interest in how do we change market forces. And this is where CMS has really kind of leaned in. They're thinking about how can we change the fundamental incentives to health systems and others in order to stimulate targeted investments in these types of social determinants of health programs. But also knowing that resources are not limitless. We only have so much money, and so much of it is already being spent on healthcare, that can we more efficiently match the resources that are needed to the areas of need? And then finally, of course, the solutions to trying to improve disparities in places like Detroit are going to be different than they are in Jackson and different than in Sioux Falls, South Dakota. And so they do need to be community aligned and tailored. And so this becomes very interesting when you think about these exposomal metrics, because from a policy level, they open the door to changing market forces. So traditional policy is at the individual level, and this is what probably most of you have seen, where an individual may qualify for a certain program and then has to fill out a bunch of different forms in order to get the food that they need, or to get housing, or to qualify for Medicaid, for instance. This is really the state of most social determinants programs. But it does make planning and targeting difficult because you're relying on an individual to submit a form. You don't know how many individuals are going to submit these forms. You have some sense based on history, but there is a lot of missingness, and the individual themselves bears the burden to file the forms. For myself, in the field of dementia, most of the patients with dementia are not going to have this capacity. They're not going to be able to navigate through these myriad of hundreds of paperwork documents in order to access the resources they need. And this leads to adverse health. It leads to individuals who are not getting the services that they need, even if they're available to them. And ultimately, it leads to more healthcare costs. So it also leads to a platform of services that are incredibly poorly coordinated. We have so much administrative infrastructure that is duplicative across these programs, and frankly, probably somewhat burdensome to the system as a whole. If we shift to an exposome level approach, and this won't work for everything, but it does work for some things. For example, incentivizing resource targeting to high DI neighborhoods within healthcare contexts. It allows for simplification of targeting because the measures are already available for the full US, and it places the burden, or perhaps the incentive, as another way of thinking about this, on the system itself or on the entity in order to target these groups. For instance, with the ADI payment incentives I'm going to show you in just a moment, it creates a market incentive for healthcare to target these high ADI contexts. And it also incentivizes coordination to improve access. So hopefully the different entities that are targeting these high ADI neighborhoods are working with each other in order to be more efficient. And this is exactly the approach that the Center for Medicare and Medicaid Innovation is taking. For those of you who are not aware of CMMI, it is a payment model testing program that was established as part of the Affordable Care Act during the Obama administration. And its main goal is to rein in healthcare spending through different ways of paying for healthcare. But it also has these other goals as well, including supporting innovation, partnering, and advancing health equity. And in January of 2023, they officially launched their ACO REACH program. And although it has many goals that align with CMMI goals, one of them was to advance health equity. To do this, they're using an innovative payment approach that grounds on the ADI that's built right here at the University of Wisconsin. I'll show you that in a moment. and require that all model participants work with communities to implement a robust health equity plan. And then these participants are also held accountable to implement initiatives that measurably reduce health disparities. This is a grand experiment that will go forward over the next 2 years. And since this announcement, again, this was just January of this year, there have been a large number of other models that have taken the same philosophy out of CMS and have moved forward. This is the health equity benchmark adjustment that CMS puts forward. This is a slide right from their own slide deck. And you can see here, the area deprivation index is accounting for 80% of the HEBA, or health equity benchmark adjustment, and being used in using the philosophy that I just shared of using exposome measures to encourage targeting of high-risk populations. Additionally, the ADI has been used in just countless numbers of local examples of resource targeting in order to try to improve the health and well-being of populations that are being served. This is just one example. I chose this because it's a local example. The city of Milwaukee, back in May, announced their new prioritization plan for lead pipe mitigation. And so what they had been doing is taking all this equipment and running to one house versus another house all over the city of Milwaukee on the basis of individual level measures. Well, this was highly inefficient, and it perhaps didn't allow them to do as much as they would have liked to do. And so they adopted this new plan that allowed them to work neighborhood by neighborhood through the city in a way that was more systematized using these mathematical equity constructs. They don't have money to do every single neighborhood across the city, but they are starting. And what you see is the press release that was released when they formally announced this program. The pictures here are of the workmen digging up the lines, and you can see the old lead lines kind of all broken and corroded, and the new copper lines that are going in place. Of course, this does not mitigate all of the lead concerns that are in the city of Milwaukee. Much of this comes from crumbling infrastructure of paint within houses and other types of exposures. But this philosophy has been so successful thus far, just within its few months, that they're looking at adopting it for other types of targeting programs. So I'll stop here and just stop with a few summative remarks. So a few conclusions and hopefully things for you to remember. So first of all, today we did a whirlwind tour of the exposome. This is a huge, huge area. And so this was just meant as a little taste of this field that may be new to many of you. So first of all, please do remember that individual level social factors and exposome level social factors are independently linked to health outcomes. One does not take the place of the other. Too often have I seen this happening within the field. Both are really, really important, and they operate in different ways. Increasingly in the physiological literature, we're seeing that they even have different physiological pathways in which they're linking to adverse health. Next, metrics of neighborhood disadvantage often reflect structural inequities, and highly disadvantaged neighborhoods are not distributed equally. So across the United States, geographically, these types of neighborhoods are in different places. They're not, and they're often clustered. So keep this in mind as you're moving forward. The ADI is an extensively validated measure of the social exposome, which links to a wide array of biological metrics and health outcomes. Just since we've released it in 2019, it's been included now in over 1,200 publications, and over 850 of these were just in the last 12 months. So the use and the tempo of this metric is increasing, including within the clinical trial space. And the Neighborhood Atlas houses the ADI and is free to all of you. So if you have interest and would like to just explore the tool, please feel free. So of course, I showed you lots and lots and lots of work here, none of which would have been possible without an entire team, an entire community of collaborators and staff and participants that made all this possible, including our over 50 key personnel of the neighborhood study, our NIA program staff, our participants, our executive committee, and the entire exceptionally talented team at the Center for Health Disparities Research, from which all of this is possible. So I will stop there. I want to thank you very, very much again for the opportunity to share this work with you and take questions.
Thanks so much, Amy. I really appreciate you you providing insight and your important work. we do have a few questions for you, and it looks like Robert Stryker has his hand up there.
Yeah, thanks.
All right.
So can you hear me?
Yep. Hey, Ralph, how
Yes.
are you doing?
Good. So this was great, and I learned a ton. But you broke down the exposome into physical chemical as one area, and environmental as a second area. And I don't know myself, there are a lot of chronic infections that some people have that other people don't have, for particularly HIV, obviously, but also Hep C, Toxoplasma, HPV, blah, blah, blah. Anyway, the point is, which of the four categories does that fall in?
Which of the four categories does HIV fall in?
No. Chronic subclinical infections.
Chronic subclinical infections. I would think that it would probably fall into all four in some cases, right? So,
Okay.
so the remember, these are not measures of health per se, right? They're
Sure.
measures of the environment itself. So, the subclinical infections would be, in the way that we tend to think about this in the exposome space, would be an outcome or something that we would be predicting. And then the different types of exposures that would be included within the exposome could potentially lead to that in a whole host of ways. So you imagine built environment, for instance, which was that top category, in which you could imagine access issues becoming a big issue if someone is in a pharmacy desert, for instance. We have the toxin and pollutant category, which includes things like lead that I just mentioned, and other types of pollutants that affect the body. The social category is often a very broad category in which social determinants of health, but also other types of policies and social supports fall in. And then the other category as well, the behavioral category, that is thought about differently by different groups, I have to tell you. Sometimes it's included, sometimes it's not, both as an individual level factor or an exposomal level factor. I like thinking about it as more of the structural resources around a particular individual that allow them to engage in certain behaviors. But that often brings us to built environment and other types of safety considerations. This is a field, the other thing about this field is it is so new in many ways. And obviously it has roots that are grounded in some of the beautiful geospatial work that have been done in ID, for instance, and in HIV, and these local level measures that have been deeply characterized by some institutions. For instance, Duke and the University of Chicago have done a beautiful job of characterizing almost each and every latitude and longitude point within those cities that they serve. But so often this exposomal study are really focused on finding these harmonizable metrics that are available not just within a single city point, but within an entire nation or within an entire state in a more harmonizable way. And of course, in building bridges and moving beyond single focus on a particular discipline to be able to link more of the fundamental social constructs and our social scientists with our fundamental biologists and biology. So I think your question is a great one, and I do think that ultimately there's a lot of work to be done. Now, of the thousands of papers that are published, I have not read every one you can imagine. So many have come out in the short time. I like get the citation alerts, but if they don't cite our original paper appropriately, then I don't even know if they're published. So it could be that there's been something out there on those types of infections. I cannot pull anything out of my brain right at this very moment, Dr. Stryker, but yeah, it can be done though, right? And the other exciting thing about using a metric like the ADI is it's policy actionable. And the characteristics of a policy actionable metric, I didn't go into. I have a whole nother talk for policy colleagues that I sometimes go into. But to be a policy actionable metric, you have to be able to technically be measured for every individual within the policy world, within a political unit, be it a county, a city, a state, or the nation. And so some exposomal metrics meet those criteria, but some do not. And so this linkage then between policy and science is also fascinating, I think.